Dear chairs, dear ladies and gentlemen, dear Florian, thank you very much for having me here and letting me give you a talk about surgical exploration after preoperative therapy. Some of my pictures you will have already heard of before, but I try to focus a little bit more on surgical questions, especially on results, but also on surgical quality, morbidity, mortality, technical aspects, and also the influence of the pre-treatment of the following surgery. When you look at the publication of VERMA, which was just recently published and is a systematic review of postoperative morbidity and mortality and complications summarizing 20 studies, you see, and this is historical data, complications after surgery alone. We all know the data about delayed gastric emptying, up fistula, pancreatic leakage between 0 and 15%, and also about the total mortality of 0 to 5% in experienced centers. But they also summarize surgical complications after groups of neoadjuvant treatments, in this case here, neoadjuvant chemotherapy, and as my former speaker already said, it's a big mixture of resected, not resectable, borderline tumors, but here are summarized, and this is an extract, resectable tumors with a variety of different chemotherapies showing results from 37 to 40 to 60% resected, and the pretty high R0 resection margin, and the mortality and the morbidities are almost the same as in non-previously treated patients. Chemotherapy doesn't influence surgery. What happens with the surgical complications after neoadjuvant radiochemotherapy? And here in this group are resectable or borderline resectable tumors. Here a variety of different trials, all with relatively small numbers, showing quite similar results as shown before. Also here, mortality rates which are acceptable, also fistula rates which seem to be a little bit low, but anyhow, there's one study which seems to be very positive with 81% resectable tumors and 100% R0 resections, probably due to a selection bias. What happens is unresectable tumors, palliative surgery after neoadjuvant radiochemotherapy. Here also an extract of a couple of studies which are published. Here the results of resections and also R0 margins are much lower. The mortality is pretty high, probably due to the advanced stage of the tumors. You already heard this morning, is there a need for neoadjuvant treatment in patients with initially resectable tumors? Here is a very nice summary, a meta-analysis from 2012. Andrioli did that with 20 studies, many resectable and unresectable tumor. And the disappointing news or the conclusion of this paper is more or less neoadjuvant treatment with marginal benefits has marginal benefits, and upfront surgery is recommended. We are based on the ISGPS consensus conference and on the statement of the International Study Group of Pancreatic Surgery, and they have these three groups, the localized and resectable cancer patients, those with borderline resectable cancer, which is mainly based on the involvement of the venous and arterial tree, and the so-called unresectable cancers, which have a large involvement of the surrounding tissue and the surrounding vessels. When you look at this classification, there are indications for surgery almost in all groups, but mainly surgery or neoadjuvant treatment is indicated in the borderline or in the unresectable group. Why not vascular resection, venous resection? Here is the paper of 2009, which was done in Heidelberg, which showed that portal vein reconstruction techniques, which has an influence also on the outcome, and the results concerning morbidity and mortality, with a morbidity of 40% and an equal surgical mortality of about 3.6%. The conclusion of this paper is that the equivalent survival is independent of the reconstruction technique or neo or no neoadjuvant treatment, and this is in line with the recommendations of the study group. What can we do if we are not sure if the portal vein is involved or not, and if there is an indication or not, and if there's a subgroup which profits of surgery? You can try to use the grading, which was published by Baninelli in interaction also with Heidelberg. We tried to grade the involvement of the portal vein in 4 grades, A, B, C, D, and D, depending on the length of tumor contact with the vessel, with the circumferential vein involvement, and the grade of stenosis. And what you can see in this paper, that the accuracy on the level of portal vein and superior mesenteric vein is quite high. The sensitivity is different. It's higher on the superior mesenteric vein level, and it's almost the same on both sides with concerning specificity. And if you look at the score, then you can try to predict the resectability rate, especially the R0 resection rate, depending on the score which declines, the higher the score is. Here are the survival data showing that when you have a high score, the trend is, it's not significant, but the trend is that you have an increased risk of death. The conclusion is that you can try to predict resectability. It seems to correlate with metastatic site, and it seems also to correlate with the resection margin. When you go back now and when we try to find out which patients or which tumors are really profiting from a neoadjuvant treatment, when we use the consensus statement again, we have to focus on patients which have arterial involvement or which belong to the group of unresectable stages. And as you already heard, FOLFIRINOX-based therapies are very popular right now. There are many publications. This publication is already mentioned. FOLFIRINOX plus minus radiotherapy was applied. The outcome parameters were resection rate and radical resection rates, and the results showed that you can resect in more than 40%. This was also shown by other publications, that there's a nice number of resection, R0 resection, but borderline resectable tumors after this treatment increased to 63%, and also the unresectable are, at least in 1/5 of the cases, finally R0 resected. What can we use when we try to indicate the surgery? And we are all based on radiology, and here's a publication by Ferrone showing on his population of 188 resections, 40 treated with FOLFIRINOX with different schemes, that the FOLFIRINOX arm has some advantages and disadvantages, especially a longer operation time, a higher blood loss probably due to the separation of the vessel tree as shown in the nice pictures before, but it seems to have less complications and less pancreatic fistula when people are pre-treated with FOLFIRINOX. And of course, as expected or as we hope, it seems that the lymph node status, the R0 status, the invasion, lymphatic and perineural invasion is better with FOLFIRINOX, but this is not a randomized study. This is not a case-matched study, and on this, the conclusion is a little bit weak. It shows that we have a resection rate which is pretty high, but they also mentioned that the radiologists are not able to really distinguish between fatty tissue, between fibrosis, viable tumor, and therefore the distinction is sometimes not possible. So the recommendation there is patients after neoadjuvant treatment should be explored. Serial frozen sections of the crucial areas should be done, and it seems that the morbidity in this pre-treated patient is equal or lower. What else can the radiology give us? Here is the study by Cassinotto in radiology based on 47 patients over a period of 4 years. All had FOLFIRINOX, then radiotherapy and chemotherapy, and then they underwent surgery. You see you have a dropout rate of about 49% when you use this protocol, but 47% were finally enrolled in the study population, and 70% were resected, R0 and 30 not. And what they could predict with the radiology is that if there is if the involvement of the axis of the veins, and if there is involvement of the SMV or portal vein, and if you see a regression of the involvement, it is associated with a higher R0 resection, up to 91% in this publication. But on the other hand, if you have no regression of the tumor, it's not predictive for R1 resection. Therefore, even in this paper, or in these cases, exploration is mandatory. Another publication for Tolakkia is telling us more or less the same story. People, 51 patients with borderline resectable pancreatic ductal adenocarcinoma were summarized in upfront chemoradiation, in induction chemotherapy followed by chemoradiation, and as you would expect, the resected have a better survival, overall survival and progression-free survival. And in 29 cases, meaning 60% resection was successful. This is in line with other studies showed by Katz. A publication was already presented before. However, tumor vessel interaction shown by radiography showed in 80% stable disease and even in 17% progressed disease. But even part of those were resected. So downstaging, as mentioned in this paper, is rare, is not always seen. The RECIST response is not an appropriate treatment goal, and no improvement is not a contradiction for surgical exploration. What do we surgeons profit from neoadjuvant treatment? There's a nice study from Takahashi, who had pre-treatment with gemcitabine and radiotherapy. The dose is not mentioned in the paper, but they could show that the fistula rate, according to the grading of the study group, is much lesser if the people are pre-treated, probably based on the radiotherapy effect on the tissue, and also the level of the amylase in the drains are much lower. The explanation by the investigators is that there's more fibrosis, perilobular fibrosis, more edema and atrophy, which makes it easier to do the pancreatic anastomosis. You all know the publication by Esposito and Verbeke, and it was also shown in the previous slides before. It is very important that we stain, or the pathologist stains, the tissue, because we can see that involvement of the tumor in the surrounding tissue is dependent on the place of the tumor and also on the stained part. And when we use the novel classification, according to these papers, R1 resections are achieved in more than 70%. But we see also results, positive results, if people with borderline tumors undergo pre-treatment. Here is one publication from Rashid. The pre-treatment is shown here, and 55 patients underwent resection, and the histological workup showed a quite nice response in the treatment in percentage here, partial response or no viable tumor anymore from 7 to 36%, and the surgical complications were lower in this subgroup because of easier surgery. Another publication by Christians shows more or less the same thing. When you look at the pathologic response, the tumor destruction, you can see after the treatment shown here that partial regression is in almost 100% seen. Therefore, Our seroresectability can be high if you pre-treat the borderline tumors. The survival is increased and the disease-free survival is also increased, and this is in line with many other studies which were published in the recent years. I come to my conclusions now. Borderline unresectable tumors are most eligible. There are the ISGPS consensus statements which are important to look at. The mortality and morbidity are comparable with those which are primarily resectable, especially when it comes to chemotherapy and radiotherapy. Surgical exploration, in my point of view, is mandatory and important after neoadjuvant treatment. We need to have a risk assessment to judge the survival benefit, the perioperative risk, and also it will be interesting to identify subgroups who will definitely profit from surgery. We need standardized techniques, we need standardized publication also in terms of tumor resection, of venous resection and reconstruction, and we need a standardized pathological workup. Thank you very much for your attention.